I am Azbek Kakharov, Assistant of Department of Traumatology and Orthopedics. Okay, lecture of common pediatric foot deformities. Common orthopedics problems in children, angular deformities, bow legs and knock knees, rotational deformities in toeing and extra toeing, leg ages, CDH, feet problems, and hip irritability. Angular deformities nomenclature. First picture is bow legs, and second picture is knock knees. Generals and generals. Angular deformities range of normal varies with age. During first year, during second year, and between 3-4 years. Angular deformities evaluations should differentiate between psychologic and pathologic deformities. Psychologic and pathologic deformities versus symmetrical and asymmetrical, mild, moderate, and severe, regressive, and progressive, generalized, and localized. Okay. Next decaded versus normal for age, exaggerated, overweight, early with bearing. Next one, rickets, endocrine disturbance, metabolic disease, injury to epiphyse plate infection, trauma. Angular deformities evaluation, symmetrical deformity. Symmetrical deformities first picture is like this. It was second picture. Third picture was baby. And last one is X-ray. Asymmetrical deformities. First picture inside. And second picture is X-ray. Yeah, it looks like X-ray. It looks like X-ray. Generalized deformity. Baby is sitting up. And it was X-ray. X-ray functions. Localized deformity. Baby pick. You can see this track swiping down there. And the bone X-ray. Swiping. Lungs. Localized deformity. X-ray pictures. It was rickets. And the next one. Measure angulation, standing supine. Baby's pick. In bow legs, general. Condylar distance inter. These ones. Measure angulation in knock knees on general. Distance inter. Measure angles directly. This pic looks more impressive, doesn't it? This one is ruler. Investigations laboratory. Serum sulcum. Serum alkaline phosphatase. Serum creatinine, urea renal function. X-ray when it's severe or possibility pathologic. Standing AP film, long film. Hips to ankles with parallel drafted forwards. Look for diseases, rictus, tibia varabulums, epiphyseal injury, measure angles. Investigations, radiological, femoral tibial axis. This picture is femoral tibial axis. Medial slope. This picture is medial physical slope. Angular deformities, when to refer. Pathologic deformities, asymmetrical, localized, progressive, not expected for age, exaggerated psychological deformities. Definition. Okay, first one is baby setting up, second one is X-ray. Angular deformity surgery. First one is before surgery. Second one is after surgery. What will happen there? Okay, rotational deformities, clinical examination, rotational profile, 3 tibia rotational arc, third foot angle in prone. Look at this one. This is how to use and how to unuse it. Rotational profile, full foot assessment, metatarsals adductions. Look at this. Searching Victoria. Victoria second one. Everted foot, flat foot. Common presentations. Infants. Seen when infant positioned upright, usually hips laterally rotating artery. Look at this baby. Medial deviation of fair foot 90% resolves spontaneously, causing fluid or presence or less in the first year. Look at the toys. Toddlers. At beginning of walking. Medial tibial torsion, metatarsus adductors, and abducted grip toy. Common presentations. Toddlers medial tibial torsions. The common cause in toying observed when management is best, avoid special shoes, splints, braces, unnecessary ineffective interfaces with activity and cause psychological and behavioral problems. Toddlers metatarsus adductus. Toy. Serial casting is effective in this age group, usually correctable by casting up to 4 years. Toddlers adapted grip toy. Dynamic deformity. Overpull abducted helix muscle during stance phase. Spontaneously resolve no treatment. Child. Due to medical femoral torsion and toying in late childhood, lateral femoral and tibial torsion. Medial femoral torsion. Starts at 3-5 years. Peaks at 4-6 years. Then resolves spontaneously. Okay. Family history normal. Persists more, not less, 8 years and causes functional disability. First one is child. Second one is not. Rotational deformity management challenge dealing effectively with family. In toying spontaneously correcting vast majority of children as LL externally rotated with growth. Convince family that only observation is appropriate. First, persons of femoral and tibial torsional deformities fail to resolve and may require surgery in late childhood. Attempts to control child's walking, sitting, and sleeping positions is impossible and ineffective, cause frustrating and conflicts. Ineffective, and limits activity, better tolerated, benefit. severe and persistent deformity, age more than 8-10 years, causing a functional disability, progressive, leg age, growing pain history, regular pain, poorly localized, bilateral, non-cultural, seldom alters activity, long duration. Examination. General health is normal, no deformities, no joint stiffness, no tenderness, normal gait, no limping, and management. When a typical history of signs present on examination, imaging, and lab studies. If all negative, symptomatic treatment, heat and analgesics, ratio family, benign, self-limiting. Congenital dislocation of hip, development, dysplasia of hip. Pterologic hip, fixed discoloration, often with other malus, completely out, may or may not be reducible, only partially in. Femoral head can be dislocated, shallow accessibility, or in a piece. Etiology and risk factors, prenatal, positive family history, preemie gravida, female, oligohydramnios, breech position, postnatal, sweating, strapping, ligament laxity, torticollis, congenital residarum. Then risk factors are present. The infarct should be examined repeatedly. The hip should be imaged by US or X-ray. The child is watching and it was clinical examination. And next one is ultrasound screening. Early US screening not recommended. Delayed US screening older than 3 weeks. Those at risk are suspicious by history and clinical exam. Best to 6 months, pelvic harness or hip space cast. 6 months, 12 months, close reduction UGA and hip space casts. 12 months, 18 months, possible closet and possible open reduction. Above 18 months, open reduction and acetyloplasty. Above 2 years, open reduction, acetyloplasty, and femoral osteotomy. Method depends on age. The earlier started easier treatment and better the results.
Okay, I understand.
Should be detected early. Written peripheral once an abnormality is detected. Anatomy and terminology. First one is treatment of varus. Second one is valgus. Okay, take care, guys. Bye.
Well,